Hello, my name is Monique Rennie, and I am the Director of Scientific Affairs for MolecuLight. Today I'm here to present a poster entitled Fluorescence Imaging and Delayed Healing are the only significant predictors of bacterial loads, more than 10 to the 4 CFU per gram, data from 350 wounds. This data is part of a 350 patient clinical trial conducted across the United States at 14 sites by 20 clinicians. The objective of this trial was to compare the ability of bacterial fluorescence imaging using the MolecuLight IX system and the standard of care, clinical signs and symptoms, to detect bacterial loads above 10 to the 4 colony-forming units per gram, which roughly equates to moderate to heavy bacterial loads. As I said, this was done on 350 chronic wounds, and the assessments were performed by 20 clinicians with years to decades of experience in assessing and treating wounds. And each wound in that study underwent a clinical signs and symptoms assessment based on wound infection checklist criteria, and a wound was considered positive for bacteria if 3 or more signs or symptoms were present. Fluorescence images of the wounds were then taken with the MolecuLight IX point of care device, and red or cyan on those images indicated the presence of high bacterial loads. All wounds underwent a biopsy to determine ground truth. Bacterial loads greater than 10 to the 4 colony-forming units per gram were considered positive. And in the example wound below, you can see the red fluorescence in the image on the right, indicating high bacterial loads. Now, the primary outcomes of this trial were to assess sensitivity and specificity, and I'll give away the punchline and say that the fluorescence sensitivity was 4 times higher than that of the standard of care clinical signs and symptoms. But the particular analysis I'm presenting today is looking at the individual data points and how they each fared on curves called a ROC curve. And these are specific types of curves designed to articulate the effectiveness of a diagnostic test in detecting the presence or absence of the disease that it's designed to detect. So on the y-axis, we have sensitivity. Sensitivity is the ability of a diagnostic test to correctly identify patients that have the disease of interest. So for example, for infection, high sensitivity would mean that patients who truly have wound infection are being caught by this test. They're not being missed. And then on the x-axis, you see specificity, which is also very important in a diagnostic test. Specificity speaks to the patients who do not have the disease that you're looking for, and the ability of a test to correctly identify that they do not have the disease. So thinking about high bacterial loads, you wouldn't want a test that would come back with false positives indicating that there's high bacterial loads when in fact they're not present. And then also on this graph, I'm showing a line of chance. Any data points that fall below this line have the predictive capabilities roughly equivalent or less than flipping a coin. So let's look at how the data from this trial fared when plotted on this type of curve. Oh, I'm sorry, and just to clarify, because the x-axis is plotted as 1 minus specificity, the area that you want your data points to be in is in this upper left corner where data is highly sensitive and highly specific. So let's look at how the data from this trial fared when plotted in this fashion. Here we're looking at all the individual clinical signs and symptoms, and you see that most of them are clustered down in the lower left corner, which means they have very high specificity, but their sensitivity is quite low. And if you look at the inset box, you can see the individual signs specifically called out with the specific symptom that they were. And you can see that 4 of the symptoms fall below the line of chance, so we're no better than flipping a coin. And the ones that did fall above the line certainly weren't above the line by much. Now let's look at what happens when you combine clinical signs and symptoms together. So you see in the blue dot for clinical signs and symptoms that when you take 3 clinical signs and symptoms as being positive for detection of high bacterial loads, the sensitivity still remained quite low, clustered down amongst the individual data points. But if you look up on the graph, you see that fluorescence as an individual data point with the MolecuLight iX device had a sensitivity 4 times as high, putting it up in that upper left quadrant where we want to be with high sensitivity and high specificity. And we also analyzed the data combining clinical signs and symptoms and fluorescence together. And when you look at that, you see that the driver of that high sensitivity is the fluorescence and not the clinical signs and symptoms. So to conclude from this sub-analysis of this trial, clinical signs and symptoms are poor predictors of clinically significant bacterial loads in wounds. Fluorescence imaging sensitivity was 4-fold or 400% higher than clinical signs and symptoms for detecting wounds with bacterial loads above 10 to the 4 CFU per gram, and it had comparably high specificity. Fluorescence was the driver of improvements in predicting wounds with high bacterial loads. And as the most effective single predictor of high bacterial loads, fluorescence imaging warrants consideration as essential information during wound assessment. Thanks very much.